All right, good morning. So we are going to continue with chapter, 7? And so last time we talked about, we are now in the realm of looking at, or the perspective of looking at, cost allocation from the perspective of if we were kind of multiple levels down from the main organization. So we started the discussion with kind of looking at cost, right, back in chapter 5. We're looking at cost and different, fixed costs versus variable costs. And then we said, well, there's another, so we have that, and we have that form of cost all throughout the organization. And we can look at it depending on time. We can look on cost, whether it is fixed or variable, right? So a lot of with enough time, everything is variable, because with enough time, you can cancel a lease, you can, hire more people, you can, right, with enough time. So a lot of these ideas of cost are around your perspective, right? So one perspective is time. That's kind of the variable cost, fixed cost perspective, right? The other perspective is kind of where do you stand in the organization in terms of looking at whether something is overhead or, or a direct cost. And so in chapter 6, we looked at, we kind of explored this idea of overhead versus direct cost, right? Where overhead, where we started to talk about how organizations, smaller organizations might come together to, in order to share some sort of cost center like IT, finance, HR, right? So one of the reasons that, so just kind of review here, right? So one of the reasons that we've seen a lot of physician practice consolidation, for example, or even consolidation between physician practices and hospitals, is so that those organizations can get bigger, right? Have more profit centers merging together so that they can take more advantage of the cost centers that they all need, right? So even if you're a small, one woman, one man shop, as a provider, so maybe you're a family practice doc out in the field, used to be you'd do that, by yourself. Then you had, with the increasing complexity of insurance in particular is one of the main drivers, you realized, I've got to hire, maybe once upon a time it was you and maybe like an LNA or something that helped you, get the patients ready. And that was enough. And then you could do the billing at night and you'd be done. And then as the billing got more complicated, you realized you needed an office manager and you needed more people, and that's expensive. And so you looked around and you found, Allie, who's down the street from you, and said, hey, Dr. Allie, you want to join my practice, right? We join together and we can have one office manager instead of 2 office managers. And so, they're, yeah, that's a good idea. But now we've got 2 practices sharing one office manager. So like, how much does Allie pay of that office manager's salary, and how much do you pay of that office manager's salary? And so that was kind of the question for chapter 5, right? And so it was a fairly simple idea of the organization being, profit centers, cost center, sharing the cost center. So with chapter 7, we're just kind of going one step further, one step more, a slightly more complex organization, where we have kind of a parent company, right? A parent, headquarters operation that includes kind of your organization level support, like facilities, like finance, right? HR, and those are the ones that I keep talking about. And then you have maybe service lines or departments, depending on the kind of organization. You'll hear both of those terms kicked around, right? Where you have a department now, and then below that, you have services. So you have just a more detailed hierarchy. And so you're going to have some costs centralized, right, at the organization level. So let's say it's a hospital. So you'll have some costs at the hospital level, and that would be, hospital leadership, maybe quality, and then finance, HR, that kind of stuff, right? It's all going to be at the hospital level. And then you're going to have departments that have, say, multiple services. Well, the departments are going to have some cost that's specific to the department, not shared by the not shared across departments, but specific to the department. So perhaps, a department chair, right? Or a medical director for a department. So maybe we have pediatrics, right? And pediatrics has a medical director. And maybe you have 3 pediatrics clinics that the medical director oversees. Or maybe you have, general pediatrics and pediatric oncology and pediatric endocrinology, right? So you have 3, you have a, primary care and 2 specialty clinics that are all kind of rolled up under pediatrics, which is something you would see, say, at Boston Children's or any of the bigger, Leahy or someplace like that, where you'd have Department of Pediatrics and then you'd have general pediatrics and you have some specialties, some specialists. You're not going to see that at Wentworth Douglas, right? But you could see that conceivably at, one of our teaching hospitals. The CHAD, the Children's Hospital at Dartmouth, for example, would be an example of that, where they have all these different children's specialties, pediatric specialties. So you'd have Dartmouth, if you think about that, you have Dartmouth, then under Dartmouth is the CHAD, right? And under the CHAD are a bunch of services. So that's the model we're thinking about. And so Dartmouth, right, has Dartmouth HR, and Dartmouth Public Affairs and Dartmouth Finance, right? And then you have the CHAD. And the CHAD has a medical director and an administrative director, right? And they also have, probably have some billing operations and revenue cycle stuff in the CHAD that also works with finance at the Dartmouth level. And then within the CHAD, you have, like I said, general pediatrics, pediatric oncology, pediatric endocrinology, pediatric blah, 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 right? No, it's all about this stuff. Pediatric orthopedics. So you have, all these different specialties. So now you can't just roll up cost at the pediatric level, right, at the department level or at the CHAD level. You have to kind of drill that cost down to the individual services. So that's what we're doing here in this chapter, is we're kind of saying, all right, we're really doing what we did in chapter 6, right? But we're just adding an additional layer. And so there's costs that are being pushed down from Dartmouth as a whole, right? And then there's costs that have to be pushed down from the CHAD administrative layer, right, down to the services where the actual money is made, right? And so that's where your profit centers are just pushed down another level. So that's what we did last time. We talked about pretty straightforward things. The stuff we did last time looks just a lot like what we did in chapter 6. It's the same method. It's that same 4-step method, right? And you just have to think about what's the total overhead. And then we just used we basically did direct method in that case, right? And you just have to think about what's the overhead that's going to be pushed down, right, to my clinics, my subordinate clinics. And that overhead ultimately consists of a mix of the share. So if this is, pediatric endocrinology at Dartmouth, right, the overhead that we're talking about trying to distribute includes the chunk of cost that's being pushed down from Dartmouth down into the CHAD. And then the CHAD itself has, like I said, an administrative layer that has to be pushed down into. So the overhead that's ultimately going to be costed out to each of the services includes organization level overhead as well as kind of departmental level overhead. Right. So that's just kind of returning to what we did. So we did cost to charges. And then I said, well, charges, I'm not a huge fan of using charges because we've talked about, the unreality of charges based on our charge master, right? We realized that Taylor just makes those things up, before she goes to lunch, right? And so we said those that, so using charges isn't really connected to reality. And if our goal is to come up with a allocation method that is meaningful, right, that is fair, we want to have that driver, rather than being something that's not really connected to, is just kind of fantasy. We want it to be connected to something. And so we said, well, instead of charges, why don't we use actual collections or revenues, right? And so we did, and it looked, as it is, it looks exactly the same. Function is exactly the same. You're just choosing a different driver, right? So you're doing the same four-step method, pool, right? And in this case is the overhead charges that are being pushed down to the clinics, right? So pool, driver, and so we talked about a couple of different drivers. One was charges, one was revenues, right? The third one we talked about was RVUs, right? Which is probably the best of the three. I'd say probably the best of the three, but you could make an argument for revenues being better. And that RVU piece just required you to calculate the total RVUs, right? Which was fairly straightforward. You just said, okay, I take the number of RVUs per visit times the number of visits. That gives me the number of RVUs for each of the clinics. Add that up, it gives me my total for my driver, right? So we said cost pool divided by cost driver gives me allocation rate, right? And then I look to each clinic to say, okay, based on the driver for, the driver amount for your clinic, I take that times the allocation rate, and that gives me the amount of cost allocated. Right? So we did all that. All right. Now we're going to actually do something that looks quite different, but still runs on the same four-step method when you get down to it. But kind of like the RVU method, it involves a bunch of calculation. And it's easy to kind of get lost in the calculations. So try to hang with me. The book does it, and I'm using the book's example. So the book, if you get lost, go back to the book, look at the book, right? But we're going to run through this now. So this is called activity-based costing, ABC. And instead of looking at costs as like this big lump, we try to look at activities that are happening to generate cost. So let me switch my camera now. Well, we're looking at the activities that drive cost in our clinic. So, and then ultimately each activity is going to require some calculations, and we're going to apply the four-step process to each. So give me, let me see. So it'll stay. So let's imagine we have a clinic, right? We were doing audiology and otolaryngology. So we'll assume still the same two clinics from before, but now we'll take a different approach. And we say, well, what costs are driving, or what are the costs of our department? Well, they include check-in, right? So this is an activity. First thing that happens is we check in, right? Patients check in. And then they get assessed, right? By, first the nurse and then the physicians. They get a diagnosis. So there's some work done to give them a diagnosis. It says, this is what's wrong with you. They get some treatment. Right? They get some prescriptions ordered. And then when they're all done with their doctor visit, this is mostly the doctor visit, right? These four steps. They come back out to the front desk and they check out. And then a bill is generated. And that's pretty much it. What we've done is we've taken the steps of our process and laid them all out. And this is for the, this is assuming we can't really sort out the different kinds of visits. So we now go back and look at what is our annual cost for each of these. And so to calculate the cost of check-ins, we might say, we're going to go through some process, say, well, how much are we paying for front desk people? How much does the space cost, right? The waiting room and so forth. And what we come up with is $50,000. Right? And then we use, and we're going to use as a driver for check-ins the number of visits. Right? So what we're going to assume is the number of visits drives the amount of effort involved in providing the check-in process. Then let's say for assessment, diagnosis, treatment, and giving prescriptions, assessment, diagnosis, and treatment, we're going to assume it's minutes of service. Right? It's the amount of time that the doctor takes with the patient. So for these three, it's going to be minutes, 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 right? And what we calculate is that the cost of this, though, is $75,000. So each of these this is all dollars, right? $75,000. And we're going to allocate assessment based on minutes. We're going to assume the diagnosis process takes longer. So that's going to be $250,000. Treatment, even longer. It's going to be $450,000. Right? And it's also going to be driven by minutes of service. Prescriptions, doesn't cost us very much because really it's just the doctor writing a prescription. So this will be a number of prescriptions. I'm going to abbreviate that, scripts. Number of prescriptions. And then the checkout process costs us $50,000 as well. That's going to be driven by the number of visits. And then billing, we spend $150,000 on billing, and we're going to assume that's number of bills generated. Now, number of bills generated, you can actually have more than one bill for a visit. So if we add that back up, add all those costs up, it's $1,027,500, which is the amount that we were working with from last time. So this is the same costs as last time. We're just looking at them in a different way. So now we look at each individual practice. So we have audiology and otolaryngology. Right? And we're going to look at the drivers. So the drivers for each respectively. So for our audiology activity and for our otolaryngology activities, we said we had 5,000 visits and 5,000 visits. Now we're going to look at the average number of minutes of service for each of these categories of service for each of these clinics. So in audiology, it takes about 5 minutes per patient to do an assessment, 10 minutes to do a diagnosis, 10 minutes to do treatment. In ENT, we're going to assume it takes 10 minutes to assess, 15 minutes to diagnose, and 20 minutes to do the treatment. We're going to assume on average that audiology generates a half a prescription, and so that means for every other, you can't have a half a prescription, obviously, right? So it's every other person gets a prescription, but on average, that winds up to half a prescription per patient. And Odo winds up with 2 prescriptions on average per patient. And then if you check in, this is not the Hotel California. If you check in, you check out, right? So this is, you have 5,000 visits if you checked in, and you have 5,000 visits if you checked out. And then we're going to assume that audiology generates 1 bill or 1 charge, let's say 1 charge on a bill, and otolaryngology generates 2 charges on a bill. Okay, so what we're working towards with this is our four-step method. So remember, and we're going to apply the four-step method to each of these costs. And then we're going to allocate these costs based on the drivers to each of the clinics. So we're basically going to do 1, 2, 3, 4, 5, 6, 7, right, of the problems like we saw in the previous chapter, or even like we did earlier in the chapter. So what we need to do now is, so these annual costs become step 1, the cost pool. Right? So our first cost pool is going to be check-in. So then we need to come up with a cost driver for check-in. We said it's going to be visits. Okay, so when we do our allocation, right, when we're trying to come up with, so when we're trying to get to our allocation rate, that is, we take the cost pool, the overall cost pool, which is the 50,000, and then we have the cost driver. We say, okay, it's going to be visits. We want the total number of visits for the department in this case, not for either one of the clinics, right? So we want the total number of visits because we're going to take 50,000 divided by 5,000 plus 5,000 is 10,000, right? And then when we do our, so then the fourth step, right, is, the third step then is to say allocation rate. Well, the allocation rate will be 50,000 divided by 10,000 will be $5. So for every visit, audiology will get charged $5. Right? And so we say, okay, audiology, each of your visits costs $5. Then we're going to do the same for assessment. We're going to do the same for diagnosis and on down. Right? So, but first we have to calculate the total that we are going to use to divide the annual cost, the total cost driver. So in this case, that's going to be 10,000 visits. Like I said, the allocation rate will then be $5 per visit, right? And then we'll say, okay, audiology, your share of the check-in is going to be $5 per visit times $5,000, which is going to be $25,000. Kind of eyeballing this, if there's 5,000 visits in audiology, 5,000 in otolaryngology. If we're saying it's, we're going to divide this cost by number of visits, you could kind of eyeball that and say, well, it's 50-50, right? So it's going to be 25 and 25. Okay. Well, it's not as simple, as we go forward. So, so now we've got that. So now we move on to assessment. And assessment, the cost pool is going to be 75,000. We said that minutes is going to be our driver. So we need, right, so rather than envisioning it, cost pool is 75,000, right? And I'm just kind of doing this offline to connect it for you. The cost driver is going to be minutes. Okay. How many minutes in total for the department are committed to assessment? Well, this is very much like the RVU example, right? Where we knew the number of RVUs per visit. And to get the total, we had to say RVUs per visit times the number of visits for each of the clinics. Then we add those two totals to get the departmental total. Just like with the RVU example, we're going to say, okay, audiology has 5 minutes per visit times 5,000 visits, plus otolaryngology has 10 minutes per visit times 5,000 visits. That gives us 25,000 minutes for audiology and 50,000 minutes for otolaryngology, for a total of 75,000 minutes. Okay, so 5 times 5,000, 10 times 5,000, add together, you get 75,000. Then, we're not doing it yet, but then the third step would be, all right, then we take 75 divided by 75, the allocation rate. 75 divided by 75 is 1, right? And then we would say, okay, how much cost, allocation amount now, how much gets allocated for assessment to audiology, and how much gets allocated to otolaryngology. I'm getting a little ahead of my example, but I'll do it here just so you can kind of see what's coming. It's $1 per minute. Audiology is 5 minutes per visit times $1 per minute times 5,000 visits. Right, so we get 5 times 1 is 5 times 5,000 is 25,000. Right, otolaryngology is 10 minutes per visit. I should have said per visit. Times $1 per minute times 5,000 visits gives us 50,000. Right. And so when we add those together, we get 75,000. So that means we've matched up our total, not there, our total cost pool. Right. So that means we've allocated properly. So this is kind of where we're going. Right now, what I'm focused on is getting to step 2. So step 2 is the 75,000. Okay, so next, we're looking for that total cost driver for diagnosis. So same process. What's the total number of minutes for diagnosis? Why don't you guys work on that for a second? So same steps as we did for assessment. We're really looking for this number, but for diagnosis now. We're looking for the total number of minutes. We're looking for that cost driver, that departmental cost driver. We can get to the departmental allocation rate. All right, so I'm going to get to that total cost driver for diagnosis. So what did you do? Right, 10 minutes per visit times 5,000 visits plus 15 minutes per visit times 5,000 visits. So we get 50,000 plus 15 times 5, I think it's 75. Yeah. So our total then is 75 plus 150, or plus 50, which is 125. Right, so the total diagnosis then is 125. And then we do the same thing for treatment. So for treatment, it's 10 times 5,000 plus 20 times 5,000. So that's 50,000 plus 100,000 would be 150. There's a lot of moving parts to this, but you've already done an example. You know, you've already done this before, right? This is it's just kind of repetitive. Okay, so then we've done that. Let me say, all right, prescriptions. So prescriptions, same thing, just different driver. So we've got a half a prescription per visit and 2 prescriptions per visit. So for audiology, it's a half times 5,000 plus otolaryngology, 2 times 5,000. Right, so we get 2,500 plus 10,000 gives us 12,500. Okay. Checkout is the number of visits. Well, the number of visits is the number of visits, right? It's 1. So 5,000 plus 5,000 is 10,000. And then the number of bills is going to be 1 for audiology for every visit and 2 for otolaryngology for every visit. So 1 times 5,000 is 5,000. 2 times 5,000 is 10,000. So we got 5,000 plus 10,000 is 15,000 bills. So remember, these are the total drivers. Right. So now we're going to make a new chart. I have check-in, assess, diagnosis, treatment, and abbreviated TX for treatment, prescriptions, RX, checkout, bill. TX and RX are common abbreviations. You will see them in your career, right? Okay, so now what we want to do is calculate the rate, the allocation rate. So we said check-in cost was 50,000 divided by the total cost driver, which is 10,000, gives us, so this is dollars per visit, right? So that gives us $5 per visit. And you want to kind of keep track of the number of, or the units. You don't have to write them down, but you want to remember, okay, I'm talking about here, I'm talking about dollars per visit. Here, I'm talking about, per minute, and so on, because you can quickly kind of, that's where this one gets complicated, is because there are multiple drivers, right? And there are going to be multiple allocation rates as a result. And so you're going to have to keep track of all these. So this will be audio, and this will be oto, and we'll have make 2 small columns here: utilization and cost. This is utilization and cost. Okay. So this is utilization. So the amount of this used per visit. So what's the utilization? How many visits per visit? Well, there's how many check-ins per visit? Well, there's 1. So the cost then would be 1 times 5. How many check-ins per visit for otolaryngology? 1. What's the cost per visit? 5. So you get cost of 5. So what we're going to do is, at the end of this, will add up and get a cost per visit. Okay. So assessment, the cost pool is $75,000. The cost driver total was $75,000. So we get $1 per minute. The utilization for audiology was 5 minutes. So the cost of assessment for an audiology visit is 5 minutes times $1 per minute, or $5. The utilization for assessment is 10 minutes for otolaryngology. So that's 10 times $1 per minute gives us 10. So far, just between check-in and assessment, the cost per visit for audiology then would be 5 plus 5 is 10. And the cost for otolaryngology so far is 5 plus 10 is 15. Right? So we're starting to already see a difference in cost for the visits. Now we go to diagnosis. We estimate we spend $250,000 on generating diagnoses. We have a total driver of 125,000 minutes. And so we get 250 divided by 125 is $2 per minute. Audiology uses 10 minutes, and otolaryngology uses 15 minutes. So for audiology, the cost is 10 times 2, which is 20. And for oto, it's 15 times 2, which is 30. So we can say 5 plus 5 is 10, plus 20 is 30, 5 plus 10 is 15, plus 30 is 45. So we've got 30 versus 45 here. Then we go to treatment. Treatment total cost is $450 divided by 150,000 minutes gives us $3 per minute. We said treatment for audiology is 10 minutes and oto is 20 minutes. So 10 times 3 is 30, 20 times 3 is 60. For prescriptions, I'm gonna have to bump up and down. Annual cost is $2,500, so that's my cost pool, $2,500. My total driver is $12,500. So we wind up with 2,500 divided by 12,500 gives us 20 cents per prescription. Right? So prescriptions, 2,500, 12,500 prescriptions. Audiology uses an average of a half a prescription, and otolaryngology uses 2 prescriptions. So utilization is a half and 2. So a half of 20 cents is 10 cents. 2 times 20 cents is 40 cents. It's a good idea. Certainly not going to take points off, but it's a good idea if you're working with a decimal to write the 0 in front of the decimal, just because if you're not paying attention, you'll go back and you'll add it as 10 instead of 10 cents, right? So just be careful of that. I recommend it. You know, I'm not going to downgrade you or anything. I just think it's a good habit. You're less likely to make mistakes. Checkout, annual cost is $50,000. Number of checkouts is 10,000. So 50 divided by 10,000 gives us $5. Now we're changing again to visits. So we have visits, minutes, prescriptions, visits, right? So $5 per visit. We have 1 visit per visit, right? So that's 5 and 5. And then bills, we said billing costs $150,000. We said that there are a total of 15,000 bills. So the cost per bill is 10. And we said audiology generates 1 bill, otolaryngology generates 2. So 1 times 10, 2 times 10 is 20. And we're done with estimating the cost per activity. And now we can roll up all these costs to determine what is the average cost of an audiology visit versus the average cost of an otolaryngology visit. 5 plus 5 is 10, plus 20 is 30, plus 30 is 60, $60.10, $65.10, $70.10, right? $75.10. Over here, 5 and 10 is 15, 45, 105, 100, I'm going to skip that, 110, 140, 130, sorry, 110 plus 20, 130 plus 40, $130.40. So that's our cost per, and we could say, we can now, if we want to verify, we could say, okay, we got a cost per, let me show you, crazy messages from my wife here. All right. So we say, all right, we've got $75.10 per visit times 5,000, well, we know 5,000 visits gives me total cost allocation for audiology of $375 and 130.4 times 5,000, 652,000. Add that together, 375, 500, and I get the 102,750. That we started with. Okay. Am I off screen? If people of Zoom, if I go off screen there, or you guys go off screen because you're watching it too, let me know. Don't need to. Must have bumped it or something. All right. So that's the process. It's not hard. It is the same steps we've done before. The main thing that people get tripped up on is they lose track of which driver they're using, right? So they, so they're saying something like, check-ins is the number of visits, but assessments is the number of minutes, and then they get turned around and they forget, okay, to get my total driver, right, they start, they forget, and they don't multiply 5 times 5,000, and they don't, wind up with the right totals. Now, it's not true that you're going to necessarily have the same number of visits. That's just how your book chose to do it. Could be you had, so part of this example works out the way it does because there's an equal number of visits, but it could just be, we could just change, oto to, or audiology to 10,000 visits, keep oto as 5,000. You wouldn't get some of the symmetry, that you do just by having the same number of visits. So the key here is we're identifying cost pools by kind of activity, right? So we're looking at, activity-based costing. We're looking at one big activity, providing audiology visit, providing a otolaryngology visit, right? But then we're saying, well, there's all these shared costs in there, and they're hard to break out. So maybe you would do this if you had shared space, if you had shared support staff, if you had, shared billing staff and so forth. So you want to be able to break all this stuff out. So you'd say, all right, you'd come up with a way of estimating how much does it cost for each of these things to be done. And then you would look at the drivers, and then you would, estimate the allocation rate per activity. So really, we're just, the difference between this and what we did in chapter 6, again, is that framing. right? How are we looking at this? So in chapter 6, we looked at it as organization to multiple services. Earlier in this chapter, we looked at it as organization to department to services. Now we're just saying, all right, we're going to just break apart the total costs of this department into its component activities that it's doing, right? Rather than looking at it in terms of audiology or otolaryngology initially, we're going to look at the combined efforts that are happening, and we're going to look at it that way. This is by far the most complicated approach. It is sort of the holy grail from, of cost accounting. Like this is like if you ask cost account, which way should we do this? It's, oh, ABC, it's great, but it's kind of, as you can see, it's kind of tedious and kind of a pain. Yeah, Emma. Yeah, so you're not going to do this and what we did, and cost of charges. It would either be one or the other. And the goal, of course, is to, let's see if I've got my notes from last time. So like this is, so our outcomes, so our outcome from the RVU method said, well, we ought to charge $69 for, or our cost for audiology is $69, and our cost for oto is $135. But here, the ABC method says, oh no, the cost for audiology is actually $75, and the cost for oto is $130. So the RVU method, the cost to revenue or cost to charge method are both cruder means of coming up with an allocation rate. You need to come up with an allocation rate of, or an allocation amount, I should say. This is the finer, this is the fine tooth comb approach as opposed to kind of the big broad brush approach, right? The cost to, but again, a lot of things in accounting come down to a cost benefit analysis. So is it worth it to get the finer, more accurate portrayal of cost, or are we good, or is the RVU method good enough? And so that's the question you have to ask as as a leader, right? Is, do I want to expend the effort to get the more accurate number, or do I want to just go with the kind of the broad brush, like it's sort of like this, right? Allie. Yeah, this would be the more, I mean, again, garbage in, garbage, you guys heard that phrase, garbage in, garbage out, right? So if this is wrong, right, if these estimates of the cost pools are wrong, because that's kind of this is where the effort is calculating these cost pools and getting them accurate. Once you have these cost pools accurate, the rest of this is, you just throw it in a spreadsheet. It's much easier to do this in Excel, or better yet, if you have an accounting program. But kind of deciding this is where the art is, and the time and the effort would be. So, so like us as finance people, we're like, oh yeah, this is totally worth it. But then you get your operations people are like, come on, good enough. RVU per is good enough. We don't want to spend any, we don't want to hire an additional cost accountant so that we can do this and get you these hyper accurate estimates. It's good enough, right? Doesn't actually change. At the end of the day, it's still $1,027,000, right? At the end of the day. So from the organization's perspective, it doesn't do anything for this, right? It still costs us $1,027,000 to deliver the care. So you really got to kind of ask yourself, it's more about, again, it's more about motivating the managers at the clinic levels to be like, this is really, really accurate, and so we're going to really tie your bonuses to that. The cruder your estimates are about, about costs, and if you're going to tie your managers' compensation to their profit and loss statement, right? So they're going to get very uptight about how accurate the costs are if their compensation is tied to a cost estimate that you and they both know is very crude, right? So your manager is going to kind of want to have a better, are going to tend to want more accuracy. But on the other hand, they're going to be like, I don't want you to be, I don't want to have to spend all this time calculating. So there's a kind of a push and pull from both sides in terms of, how much effort and accuracy do we want to put into it. That's always a little bit of tension, between finance and operations. And it's the same kind of tension between administrators and providers, right? Because we want to get these really accurate systems in place, and the providers are like, you are using up my time. I would rather be spending with patients. So it's the same kind of tension, in this case, between two administrative staffs as opposed to between admin and providers. Make sense? You guys with me in Zoom land? All right, Raina, I see you nodding your head. That's good. All right. So let's see, how are we doing on time? Oh, we've got plenty of time. So that's ABC. My experience is most organizations don't use it. They use the more crude method because ABC, like zero-based budgeting, is a lot of work. And so, they typically, I think most organizations come down on the side of it's not worth it, right? So, all right, now we're going to do a little more theoretical stuff for the balance of the time. And this goes to, and when we next semester when we do econ, because you'll have me for econ next semester, as it turns out. We will talk a lot more about these concepts. So we're going to kind of introduce them in this chapter, but we will spend a lot more time modeling this and thinking about it. So we're going to start with this idea of price takers versus price setters. So what is the difference between a price taker and a price setter? Well, it comes down to what's called market power. Let me just get a fresh pen. So a price taker is, so imagine you are, and these concepts explain a lot about what's happening in the healthcare industry in particular. So they're important ideas. Imagine you are, Deborah's gone to medical school, and then she went on to get her family practice residency, and she hangs out shingle after graduation. She starts her own sole proprietorship, right, where she is, starts seeing patients. Now, the reality is most patients have insurance. And so Deborah sees, Chloe, right? Chloe comes in, and Deborah says, how do you want to pay today, Chloe? And Chloe says, well, I have Cigna, right, health insurance. And Deborah says, okay. Well, I'd like to charge you $100 for today's visit. And Chloe says, okay, well, here's my, talk to my insurance company. And so Deborah, calls up the insurance company, calls up Cigna, and says, my bill is $100 for seeing Chloe. And Cigna says, ha, 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 that's really funny, Deborah. We pay $50 for outpatient visits. And Deborah says, well, but I'd like 100. And they say, ha, ha, ha. Just, you funny family practice people, you make us laugh. No, 50. And so that's an example of, and so Deborah says, okay, I guess I'll take 50, because Deborah knows that if she doesn't take the 50, Chloe's going to go to see Dr. Emma instead of her, right? Because Dr. Emma also has a practice just down the street, and Chloe, even though she likes Deborah, if Deborah won't take her insurance, Chloe will take her business to Emma. So that's the reality of being a price taker. In this case, Deborah is a price taker. She doesn't have negotiating power, right? When I say that the insurance company just laughs at her when she tries to negotiate a higher rate, what I'm saying is that the insurance company has market power. Market power means you have the ability to set a price in the marketplace. The reason that the insurance company has market power and Deborah, sole provider Deborah and sole provider Emma don't have market power is because there are multiple sellers in the marketplace and one buyer, right? The one buyer is the insurance company, right? So if Cigna is the only game in town, right? And Deborah's like, well, I really want to make some money because I have all these huge, medical school loans to pay back. Deborah basically just says, well, I guess I will take, right, whatever the insurance company offers me. And so the insurance company has market power because there's, right, one buyer, right, and there are lots of sellers. You've heard the phrase monopoly, right? I'm sure, like the game. Monopoly is when there is one seller and many buyers. This is actually called monopsony versus monopoly. Monopsony is this one, right? Is this arrangement where there's one buyer and many sellers. Monopoly is the inverse, where there is one seller and many buyers. So for example, if you live in Durham and you want cable, you can choose from Comcast. And that's it, right? And so Comcast can basically be like, yeah, it's $200 a month, but I really don't want to pay too bad. We're the only game in town. Do you want cable or don't you want cable? Right? Well, if you want cable, you're going to pay $200 a month. If you live in a bigger city like the Boston area, probably you have choice of 3 or 4 cable providers, and they bid against each other, and the prices in those communities is going to be lower because because the seller does not have monopoly power. Monopsony is just the opposite arrangement, where and this was the reality that many providers found themselves in, where there were just a couple of, in this case, not just one insurance company typically, but just a couple of insurance companies and many providers. And so the many providers, because the insurance company, what the insurance company does when they set up a network, right, is they say, it doesn't really work the way I just described. Really what happens is Deborah sets up a shop, and then she knows who the major providers are, the major insurers are in her community. So Cigna would be one if you're in Durham. The Cigna holds the healthcare contract for UNH. So if you're a provider in Durham, you have to take Cigna, right? And so so they call up Cigna and they're like, I would like to be, Deborah calls up Cigna and says, I would like to be in your network, right? I would like you to give me preferred treatment in your network. And Cigna says, we pay $50 per, per a 99213, we pay $50, right? And Deborah can try to negotiate, but if there are many single family practice providers in Durham, so Emma and Megan and Taylor are all family practice providers in Durham, Cigna says, if you don't like it, we'll just direct our patients to Emma or Taylor, right, or Megan, and you're on your own. So that is an example of monopsony power as opposed to monopoly power, market power, right? So market power just means whoever has market power gets to set the price. whether that's the buyers or the sellers. So if you have market power, so in this case, the buyer would have market power. The buyer would be the price setter, and the sellers, so the buyer would be the insurance company in our example, and the sellers would be the providers. Right? And so in this case, these guys are price takers, and the insurance company is a price setter. As you increase the number of buyers, right, relative to the number of sellers, the relative power of the buyers goes down, and the relative seller, relative power shifts, so that there's more of a neutral situation where, if there were 3 big insurance companies in town, Deborah could say, well, I'm not going to take 50. I guess I just won't see Cigna patients. I'll just see the Harvard Pilgrim patients and the Blue Cross patients, right? And I just won't take Cigna. And then Cigna will be like, oh, all right, we'll give you $55, right? But so if Deborah has a choice, she may not be happy about it, but she'll be able to negotiate with, say, Cigna, Blue Cross, Harvard Pilgrim, right? When it's just Cigna, she's kind of out of luck. But if there's at least a couple of providers, she gets some market power, right? Still not very much. What's the trick? What's the trick to try to change this arrangement, to change the power? What's happened in reality in the healthcare space, in the healthcare industry, to try to change this arrangement? So we've talked about it already.
Providers go into networks with each other, so they
have. The buyers are going into a network with each other.
Yeah.
So that's true, but the first response would be the sellers, the providers, start to consolidate into larger group practices. Right? So what we saw was the insurance companies came online, they had a lot of power, and they started really ratcheting down on the providers and reducing reimbursement to the providers. And the providers started saying, ow, you're hurting me, you're taking away my money, right? I can't pay my medical school loans. And so to try to fix this situation, what Deborah says is, Deborah turns around to Taylor and says, why don't we get together, right, and set up a group practice, right? And Emma leans across the hall to Megan and says, hey, why don't we get in a group practice, right? And pretty soon, you've got the doctors are in group practices so that they're effectively reducing the number of sellers in the market. And remember, what I said was, as you increase the number of sellers or buyers, it changes the dynamic, right? So as you approach a more equal number of buyers and sellers, neither party has market power anymore. And so by consolidating into group practices, right, the providers reduced the number of sellers that the buyers, the insurance companies, could negotiate with. Because whereas before there were 12, there were 12 providers in Durham, right? Now there's just 3. So if Blue Cross, goes to practice group 1 and says, we'd like you to be, take $50, they're like, hey, pound sand, we're gonna, go with Cigna and Harvard Pilgrim. And you can see if one of these other provider groups will take your $50. And the other provider groups, they're like, no, we're not gonna take $50 either, right? And so it forces the buyers to compete amongst each other and the sellers to compete amongst each other, right? And, this works so well that these two groups, they're like, hey, this group is big. It's got even more market power. They're able to get bigger numbers out of Cigna and Blue Cross, and we're going to join up too, right? And so the two smaller practices join up. So now there's two practices, each with 6 physicians in it. This is just purely accident the way I drew this initially, but it's working out really well. So now there's just 2 practices with all 12 providers are split between 2 practices, and there are 3 insurance companies. So now the practices are like, you can either, hey, Blue Cross, we're happy to be in your network, but you're going to pay us $60 per visit, not $55 anymore. And if you don't like it, you can go try talking to practice B over here, right? And practice B is like, hey, we heard that practice A is saying that they want 60. We want 62. So tough luck. You're going to pay us 60, right? And so then pretty soon, all these guys have to pay 60. Well, the problem is if they have to pay 60, their profitability goes down, right? They're not making as much money. And so they're like, well, what do we do? Well, what do they do? What's that? They can't raise their premiums because well, they could, right? But the problem with them trying to raise their premiums is the customers will just move. So what do? What have they done historically? Let me give you a hint. They do the same thing as the providers do. They join up, and they go from 2 to 1, right? And now we've gone back from 2 sellers and 3 buyers to 2 sellers and 2 buyers. And so this increases their market power and increases their negotiating position, right? And then maybe they just wind up swallowing that one too, and now we're back to 1 buyer and 2 sellers, which is a lot of what's going on in the marketplace, especially after the passage of the ACA. We saw this wild consolidation in the insurance markets, where insurance companies were just going out of business or selling themselves to other, and consolidation. So there's been this huge amount of consolidation over the last 10 years in the insurance market. And we continue to see, as a result, kind of this feedback between, as this side gets more powerful by glomming together and merging, this side, the provider side. So as the insurance companies get bigger and more powerful and exercise more market power, the provider side also continues to come together. And so we look at things like the Mass Gen Brigham system, right? I mean, if you're from the Boston area, chances are your hospital is either part of Mass Gen Brigham or Leahy Beth Israel, or whatever they call themselves, right? And that's it, right? 20 years ago, you had 50 different hospitals that were all pretty much independent. Maybe 30 years ago, right? But whatever. And now, it's basically, you're either going to a Mass Gen system hospital or you're going to a Leahy system hospital. In New Hampshire, when I first got here, there's 26 hospitals in New Hampshire. When I first got here 5 years ago, the majority of them were independent. 5 years later, the majority of them are part of some system, right? We're up in the North Country, we've got 3 now, 3 critical access hospitals, really small hospitals. It was initially 4. All got together. It was Littleton and AVH, and I want to say Cottage, and one other one. I don't remember off the top of my head. They all got together, like these little dinky no offense to my friends up there, but these little dinky hospitals, right, all got together in a system, right? Catholic Medical Centers absorbed Wolfboro and Monadnock, right, into Granite One, and now and Dartmouth already had Cheshire, and what else? Alice Peck Day, right? They're going to suck up a Mount of Scutney. They're probably going to pick up Valley Regional, right? And then they're now merging into one entity with Catholic. So it's going to be like 7 hospitals in one system. in New Hampshire, but Wentworth Douglas sold itself to Mass Gen. Exeter is trying to sell itself to Mass Gen, right? Who else is going? Elliott and Southern New Hampshire came together into one system, right? There's like nobody left. Concord, right? But it looks like Concord is going to suck up LRG probably. So then they'll be gone, right? Or not gone, but they'll be, So what we're seeing is this process very actively happening in New Hampshire, like in real time. Like you can barely stand still, and suddenly another hospital has merged with, And the reason is, amongst other things, trying to get better rates for reimbursement by coming together and reducing the number of sellers. It gives the sellers more power, more market power over the buyers. So in the case that we're talking about here, the sellers are the hospitals because they're selling their services to the insurance companies who represent us, right? So that's really important to understand as in terms of what's happening in our marketplace. So buyers and sellers consolidating changes the market power dynamic. And so market power really is the question, do you have market power? The answer is, or the way you figure that out is, are you a price taker in the sense that if you are selling or buying, you just have to take whatever price is offered to you, or do you have negotiating power? Can you set the price that you're selling at? And it usually comes about as a result of having, either more sellers or more buyers. So in this case, if we have one buyer and two sellers, there's some monopoly power, meaning the buyers have power. If there's one seller, monopsony power. If there's one buyer and multiple sellers, that's monopsony power. That means the buyer has power. The thing that you hear more often about is monopoly power, which is where if we had one seller and multiple buyers, right, that's monopoly power. One seller, many buyers. Monopsony, one buyer, many sellers. So when we talk about the recent election, there was a lot of talk about single payer. So single payer would create one buyer and many sellers. And so what we're talking about with single payers, we want to create a monopsony where the government is the only buyer. Right? Single payer government would be the only buyer. And what would be the natural reaction then in the marketplace based on our conversation in terms of the sellers? What would happen? Would you have many sellers or do you have few sellers? If the government stepped in and said, we're going to make a big monopsony, what's your instinct at this point? Lots of sellers? You'd see lots of consolidation. First of all, lots of people go out of business because the government would offer too low of a rate. And then whoever's left would merge, right? And so you'd see even bigger health systems. Single buyer. The incentive would be for all the sellers to come together so that they could negotiate better with the government, right? Well, drive it up, right? Because the government's going to want to pay very little. And so they want to make the government pay more. Exactly. So that isn't the only reason, right? Competition, price setting isn't the only reason for consolidation. The other big reason is the thing we've been talking about, which is economy of scale, right? By coming together, we can share those common expenses. We talked about IT infrastructure, finance, all that stuff. It's often cheaper to have, one finance office shared amongst a bunch of practices rather than each practice having its own finance office. All right, that's a good place to stop today. We're going to talk some more economics next time, which is fun. Yeah. Oh, any questions? Any questions from Zoom? You good? All right, Sarah, very good.